They'll get to the point where they need the anchor of the rotator cuff to hold them, and their arm just drops. So that's what the positive drop arm test is. X-rays for these are typically normal. We would look for spurs off of the acromion or the AC joint that could possibly be an etiology for poking it and causing it. And then the MRI is diagnostic because you can really see it on the MRI. If you look at the MRI that's up here, this is the edge of the tendon right here, the black. The white is all the white is fluid, swelling, okay? And this is where it was supposed to attach. So this one's retracted a centimeter or two right here. We need to take this end of the tendon and bring it back over here and reattach it to the bone. And that's where the fun is, because we do that. Typically, that was done open surgery, where you would separate the deltoid off of the bone and repair it back down into the bone with anchors or sutures. Now we do it a lot of times through the arthroscopy, through the arthroscope. But it still takes a good 6 weeks to heal. And what we look for on the MRI is atrophy. Because if they're in the supraspinatus muscle, it's not likely that the repair will be successful in terms of healing. It may be successful in terms of relieving the patient's pain and improving their function, even if it doesn't heal, just from getting the scarred, inflamed tendon out of there. But it's not likely to be a successful anatomic repair. So we do look for atrophy in the muscle. Treatment is usually surgical for this. They do not heal on their own because all that joint fluid is keeping the tendon from actually touching the bone. So it can't heal down without help. Cortisone and physical therapy can help patients become asymptomatic who are over 60 and not very functional. But this is not something you want to leave untreated in a younger person, because you don't want them to end up with this cuff tear arthropathy, which is the last thing that I'll talk about, which is a very difficult problem to take care of. This can be very painful and debilitating, because we have to leave you in a sling for 4 to 6 weeks while this healing is occurring, and you just do physical therapy to maintain your motion with gentle passive range of motion, meaning a therapist or somebody else is moving your shoulder. After 6 weeks, then we get the therapist involved in teaching you how to use your shoulder again and using pulleys to use your other arm to move your shoulder. And it can take up to a full year to get a full recovery where you're back in the gym, lifting weights, getting back to your life after a rotator cuff repair. These images show here on the diagram, this is the tendon, okay, where it's torn, usually just like this, about a centimeter off of the bone insertion, and retracted back to various degrees. This is an arthroscopic picture of it. This is an MRI. So this just looks like the other one, where here's the edge of the cuff, here's where it tore off the bone, here is the bone in this picture, and here is the horseshoe-shaped tear of the cuff. And then this is an arthroscopic picture of what a repair looks like. So these sutures that go through the cuff are then anchored into the bone with absorbable anchors, and they're holding it down to this bird portion of bone. So once this camera comes out and the fluid comes out, this bone will start bleeding, and that will stimulate the healing of the cuff down to the bone. Labral tears are another very common. These are more activity related. These are not usually degenerative. Labral tears happen usually from throwing or weightlifting activities, or from a shoulder dislocation. You get an anterior labral tear typically, and that is called a Bankart tear, if you've heard that term before. Physical exam is positive for this with the O'Brien's test. It's similar to that biceps tendon test, because the SLAP, you'll hear the term SLAP tear, that stands for superior labrum anterior to posterior. So the labrum is a rim of cartilage that goes around the socket. At the top portion is where the biceps tendon attaches. So if you have a traction injury to your biceps tendon, typically the tendon doesn't rip, it's the labrum that rips away from the bone. And that's what a SLAP tear is. That happens typically throwing a ball or bench pressing or having a hyperextension injury to the shoulder. And we can repair that back to the bone. The anterior instability, which is the dislocation or when the labrum rips off the front and the lower third of the socket, that's where the anterior instability comes in, and that's something we diagnose with an apprehension test. So we lay the patient down on the exam table and bring their arm back, and when you bring their shoulder back, they get scared, like their shoulder's going to come out. And the simple test is pushing on the front of your shoulder, on the front of their shoulder, to relocate it. It takes the pain away. So that's a positive apprehension test. And that occurs with somebody who's had a shoulder dislocation and typically has an anterior labral tear. Usually these are surgical because, again, the joint fluid pushing through there, they don't necessarily heal on their own. We do give them a shot for first-time dislocators. Most orthopedic surgeons will not operate on that right away and see if they scar down enough not to come out again. And it's age-related. The younger the patient is when they get their dislocation, the more likely they are to have recurrent dislocations. So it's like 90% of people under 20. So they typically do end up needing surgery, whereas older patients, they actually have a higher incidence of tearing their rotator cuff at the time of dislocation, but not of having recurrent instability requiring labral repair. So that's the scoop on the labrum. If the patient has developed a superior labral tear, and it's an older patient, meaning older than 35 or 40, if you do a typical slap repair, if you just repaired the labrum back to the bone, there's a high incidence of those patients getting frozen shoulder. So the options are to adjust the rehab for that, and it's really, this is where the art comes in. You know, you really have to sense what the patient is motivated to do. Or you can take care of the problem by cutting the biceps tendon so it's not pulling on the labrum and hurting the patient, and do the tenodesis or tenotomy, and that takes care of the labral tear for the older patient. After repair, patients are typically in a sling again for that magic time of 4 to 6 weeks while the healing's occurring, with physical therapy for getting their range of motion back, and then the return to throwing sports is typically 4 to 6 months from a labral repair. And this is MRI of the labrum. This is the triangle, is the superior labrum, and the fluid is creeping up between the socket and the triangle is showing you where the tear is. This is what the labrum looks like arthroscopically. This is the glenoid. This is the biceps tendon. Okay, and this would be the superior labrum coming down into the anterior labrum right here. And this is an arthroscopic picture of a repair. The front of this has been roughened up with a curette, and then this right here is the end of the tails from a suture. This is the suture going around the labrum, tacking it back down to the socket, and there's another one up here. A frozen shoulder is terribly painful. It is where the capsule of this is very fibrotic and stiff and contract, and patients lose their range of motion. We have no idea what causes it. It can occur after a trauma, but it is very debilitating because it's painful. Patients are stiff. They lose their function. It does tend to be worse and more recurrent pain. And typically, patients will lose external rotation first. So we try. This is the test before, and we look for asymmetry here on their external rotation. X-rays are typically normal. Some people who are really good at reading MRIs can see that there's anterior capsular thickening. We don't really communicate with the radiologist, so they have to be really good to pick this up because, of course, they're not going to talk to the patient. With the frozen shoulder, the treatment is usually, if you give these enough time, they tend to resolve on their own. But it's time in this inpatient world we live in is 2 years. It takes 18 months to 2 years. Nobody wants to put up with that if I can take care of it in literally about 15 minutes in the operating room. So with physical therapy, cortisone shots and anti-inflammatories is typically how we start. We'll give them a good 6 to 12 weeks to try to get better on their own. And if that doesn't work, then a manipulation and an arthroscopy to break up the scar tissue and adhesions takes care of it immediately. And then aggressive physical therapy to maintain when we get the OR for 2 weeks, and then it's is the way the treatment is going.